Okay, I think we'll begin promptly at 12:30, right on time. This is great. So welcome everyone to the McMaster Midwifery Research Center rounds. Today's rounds are part of our regular series that we've been hosting for the past few months. It's open to everyone, and our intention is to share the latest midwifery research, obstetrical and perinatal research, and to showcase midwifery researchers across the province. So we've got a really great talk today. I'll tell you a little bit more about our speakers in a moment. First, I want to let you know my name is Beth. I'm the scientific director of the Research Center. I do encourage you at this point to ensure that your mics are off and your video is off. We will have time for questions at the end today, and you can certainly turn your camera and your microphone on at that time. And before we really dive in, I want to just take a moment on this chilly first day of March to let you know that I'm here today on the McMaster campus. McMaster is located on the traditional territories of the Mississauga and the Haudenosaunee nations, and is within the lands protected by the Dish with One Spoon Wampum Agreement, which is also directly adjacent to the Haldimand Treaty Territory. And I think when we offer a land acknowledgement, it's an important moment to pause and to reflect and to be mindful of it goes beyond these words, that it's not just a token action at the beginning of an event like this, but that really it's a call to reflection and mindfulness, and to think about our actions that go beyond those words. So as a settler on Turtle Island myself, I'm trying to commit to actively reflecting on fulfilling those treaty responsibilities. And I offer this land acknowledgement in the spirit of reconciliation as we seek to respect the history and spirituality and culture of Indigenous peoples. We have two excellent speakers joining us today to speak about a topic that I know many of you are very passionate about, related to burnout in midwifery. And I would like to introduce you to our speakers and then give them as much time as possible, because I know they have lots to say and you have lots of questions. So we have Andrea Lawlor and Meagan Furnivall joining us. A little bio background for each of our speakers. Andrea is an associate professor in the Department of Political Science at King's University College at Western, and her research focuses on Canadian law and public policy, with a specific focus on administrative law and health and social policy. Meagan is a registered midwife practicing in London, Ontario. She's focusing on building midwifery research capacity in that community in her role as a clinical research lead at London Health Sciences Centre. Meagan's research interests include how midwifery students and obstetrical residents learn and understand shared decision-making, and the safety and implementation of skin-to-skin contact in following cesarean section, and interprofessional collaboration and sustainable midwifery practice. So the plan for the rounds today is that Meagan and Andrea will present for about 45 minutes, and then that will allow us about 15 minutes for questions at the end. And we'll just kind of facilitate that as we go. I'll keep an eye on the chat, and we'll also, of course, allow people to raise their hands and chime in with questions. So welcome, Andrea and Meagan, and I will turn it over to you.
Wonderful. Thanks, Beth. So I'm going to share my screen so that we can go ahead. I think Rash, you just need, yeah, perfect. I was going to say, I think I need to change that. Perfect. Okay. So let me just open this up for everyone. Okay. So I was just joking that this can be a hard topic to talk about, because it can feel like pretty draining for people. But I think it's really important that midwives not only understand the landscape of the current evidence and what's going on in burnout in midwifery, but also really try to identify what burnout actually looks like. Because I think a lot of times burnout feels like our baseline, and it's hard to tell what burnout really is and how to prevent it and how to address it. So today we're gonna start by just mentioning that we have no conflicts to disclose. And we did receive some funding from King's University College Excellence in Research Grant. And we're going to kind of go through the presentation by identifying what burnout is, why we should care about it, some of the study findings that we found in our study, our pilot study, and then the current evidence on burnout, as well as some future directions. So what is burnout? So burnout is defined as a state of sorry, let me just flip this here. I've got to move my screen around here. Okay, so burnout is defined as a state of physical, emotional, and mental exhaustion that results from long-term involvement in work situations that are emotionally demanding. This could also be applied to, being a mom and just being really involved in caretaking all of the time. So this is the definition as far as midwifery burnout is concerned. What I think is important to understand is that emotional exhaustion occurs in cases where professionals feel as if their emotional strength is being depleted. And as a result, they don't effectively engage in their work. So as they become more emotionally exhausted, that's kind of the first phase of it. They're not able to respond to the needs of their clients. They undergo a few other things that make it difficult for them to perform their role. The second characteristic is around depersonalization. And depersonalization, I'm going to talk about in a second because I think it deserves its own kind of spotlight. And then the third characteristic refers to reduced personal accomplishment. I think this is really interesting because this piece of burnout is the part where, as clinicians, we sometimes feel like we're not good enough, like we're not performing well enough. We're comparing ourselves to colleagues. We feel like we're clinically skill deficient, or the workload is too heavy and we just can't cut it. And that is a symptom of burnout, and we need to be aware of that. So what does burnout look like? So I'm not going to get into all of the things that happen when you're burned out physically, because to be honest, it's very complicated. Everything basically can be caused by stress and burnout. So one of the things that I just want to really focus on is just the mental health piece, because I know that is really prevalent in midwifery, especially in Ontario. And the piece about absenteeism. So it's important for us to understand that, we see more absenteeism, and we certainly identified it more in the pandemic, which we'll kind of touch on in our own findings. But burnout really is associated with a lot of our day-to-day work as midwives. I want to just comment on, the depersonalization piece. So depersonalization is the term that is used for when clinicians react to their emotional exhaustion. So what they do is they distance themselves from the client, and they can develop a cold and cynical attitude as a result. And so if you sit back as a midwife and you think about your colleagues or even yourself at times and some of the demands of client care, I think we can pull on some examples of what that looks like, and feeling the cynicism that sometimes goes around in midwifery practice cultures. And that is definitely a sign of burnout. And then the other piece is detachment. So detachment involves when midwives, during times of heightened stress and anxiety, we can detach to the point that we really have a hard time empathizing with the client. And this is where we see burnout negatively impacting client care and being associated with poor health outcomes. So just really understanding the degrees of burnout. So I think as a midwife, the reason why this is so important is because if you're a leader in a practice group, or you're a midwife, even just on a team of midwives, it's really important that you can sort of recognize what this looks like, because it gives you a chance to make a plan and to support yourself or to support other people. So a first degree burnout, or that sort of first stage, is usually short-lived. It's when you get occasional symptoms and they're kind of resolved with a short break. So you kind of recognize that, like, today is a bad day. I am shorter than usual. I feel like I've got not much in the tank. And this is, I'm getting that first degree burnout. So second degree is when you have more regular symptoms of burnout. You see more depersonalization, you see more detachment. It's harder to eradicate, and exhaustion may persist even after a short break. And then the third degree is more severe, and it's where, a relief from these symptoms of burnout is even harder to get. Even with professional help, it's hard to address these. And that's where you usually see more of the physical and psychological problems that come from burnout. So why should we care? This might seem like a silly question because we know that burnout it's a phenomenon with really far-reaching costs. It really permeates into everything that we do. It affects job satisfaction. It affects the amount of sick leave people require. And we're going to talk a little bit about who, as midwives, is more vulnerable to burnout. We're going to, we look at intention to leave the profession, which is something that we looked at in our research. It's very much tied to whether we're going to stay or leave. Staff turnover is a big one. This is more from the data from some of the existing meta-analyses, but even if you look at MPGs or the organizational level in hospitals, you see a lot more turnover and that poor quality of care. And what we know is that midwifery care meets what we call the triple aims of health system improvement. So midwives have good outcomes, which I know we're all aware, and there was a study just published that is amazing and showcases Canadian data on how we perform in low risk and high risk client care. So midwives provide good outcomes. We have high patient satisfaction or client satisfaction reports. And we already have pretty low per capita costs. So it would make sense that helping midwives stay in the profession would be a high priority item because we're excellent in the healthcare system, very, very much associated with the kind of care that people really should be receiving. So the methods for the study, what we did is we adapted the Copenhagen burnout inventory, and we asked a couple of other questions pertaining to the pandemic, other questions pertaining to lifestyle factors like the amount of self-care, nutrition, physical exercise. And we started with the survey, and then we did 10 follow-up semi-structured interviews. And then the themes and the questions for the interviews really came from the survey data. And those themes were around things like levels of stress and burnout, identifying the causal factors, the time horizons for these factors, the proposed solutions to these issues. And then we used an adapted grounded theory method, which was coded by 2 researchers. So that's sort of what we did in a nutshell. And then the sample that we used before we go into the findings was a sample the survey was really done between October 7th to November 4th, 2021. We had 59 midwives in the department, 43 were currently practicing, 16 were on leave, and there were 4 different MPG groups, midwifery practice groups, that were participated in the data collection. And so we had a 64% response rate, which according to the current data is a higher response rate than some of the other studies that have been published. So I'm going to pass it off to Andrea to go through the findings.
Thank you so much, Meg. And I'll get you to Meg's driving the PowerPoint bus, so I'll ask her to advance to the next slide. So in our survey, and also these were the themes that structured our interview guide, we were looking at the way that retention, call model, compensation, interprofessional working dynamics all could potentially contribute, amongst other factors, to the existence of burnout across midwives in the London Middlesex region. And on to the next slide. And we found that and we were testing for, and we hypothesized that burnout, of course, as we know from the literature, is not just a point in time factor. And it is not simply something that you can locate or articulate as the product of one event. And it is so tempting, and we were in the field, really in the thick of COVID. It is so tempting to attribute burnout to COVID. But what Meg and I wanted to do was to take a look and say that, yes, COVID is 100% a potential catalyst for burnout, but we don't think that burnout is located specifically in the space of COVID. That, as all healthcare practitioners can experience, that burnout is something that comes to people at different points in their career with a set of different experiences and lived realities. So we didn't assume, or we didn't hypothesize, that COVID was necessarily a cause of the burnout, but that there were short-term stressors such as COVID and such as the accompanying supply shortages. But there were also more systemic factors that would drive burnout. And these include the longstanding institutionalized structures that exist across the profession. And of course, we are mindful that as much as we can attribute burnout to any sort of systematic or short-term issues, that it will always be the individual level factors that may predispose somebody more readily at a particular time in their life or their career cycle to burnout. So we recognize this complement of factors. And on to the next slide. As Meg suggested already, we have a 64% response rate, and we're studying within a particular region. So it's important to note that for those outside of the region, you may see yourself in some of this data. You may feel that this reflects your experience, or it may not represent your experience, but will suggest that this pilot study, and it is a pilot study, probably has some generalizability outward, but we don't make any specific claims that, absolutely this represents Ontario or this represents the experience of Canadian midwives. It really is a representation of the population that we surveyed. And of course, we've got a distribution of age groups and years in midwifery, and this was important to us because we wanted to be able to break down our data by these very important variables, because life cycle and stage in career are very much known in the research to influence health and well-being outcomes. And on to the next slide. We looked at other factors that we think might drive burnout, such as being in a caregiving role, whether that was having young children, having a partner or a parent that you were responsible for providing care. And we also looked at the responses by type of call model, because structural factors such as the way that your practice group operates may also contribute to levels of stress felt by midwives in the region. And so getting into the start of the findings, what we wanted to do, and of course, this is an observational study, so we're gauging information at one point in time, but we asked midwives to reflect upon their stress levels pre-COVID-19. Now, this is a very difficult metric, because when you're asking somebody about their stress in the middle of a pandemic, even when you're asking them to assess their pre-COVID, right, there's always a little bit of the way that they're feeling right now may factor into this. But what's really interesting about this data is that we see what, a normal distribution of how did people feel before COVID-19. And generally, the modal response was that they felt moderately stressed. And, for people who work in healthcare and for, people who are experiencing a high pressure work environment, this sort of normal distribution might be what is expected. But we see when we look at since COVID, how stressed have you felt? Obviously, there's that push more toward the moderately, very, and extremely stressed side of things. And so we do see a bit of that situational factor of COVID-19 placing those additional pressures, those additional stresses. And we see 71% of midwives did report that their mental health was worse in COVID than it was prior to, and that, almost half are reporting that they are at a moderate or high level of stress since COVID. And one of the things that I know that people will, who are in practice will have felt, is that the number of hours of unpaid work or over and above service was much higher during COVID. So we saw this phenomena where most people were reporting that they were doing 5 hours or more of unpaid work per month in order to sort of catch up or to provide the level of care that they wanted to provide to clients during this time. Some were working an extraordinary amount, 20 weeks or 20 hours or more over their normal schedule. So it is important to reflect on the fact there was a lot of unpaid work happening, and I, would suggest probably continues to happen. Where we see, if there is one point in the survey where I think both had a oh moment, it was in this data here. And this was reports on likelihood of leaving the profession. So we saw that almost all midwives were reporting that they were likely in some capacity to leave the profession, particularly within the short term, the 1 to 3 years. And we particularly thought this might be related to where the individual fell within their career cycle. And we do see higher levels of reported attrition or desire for attrition in amongst midwives who had been, who were more early career midwives. So there was a high number of midwives overall who reported considering transitioning out of the profession, and some of the interview data brought up that, individuals didn't want to leave healthcare, and they specifically did not want to leave maternal health or health for newborn, but they weren't seeing themselves in midwifery as a practice moving forward. And one of the foci that we had in the survey was, as Meg mentioned, work-life balance, sort of personal health factors. And of course, we know that one of the ways in which people are able to recharge and recover from those first stage stressors that Meg mentioned is with time off and the achievement of work-life balance, which always feels so elusive. I mean, regardless of profession and life stage, work-life balance is something feels aspirational at times as opposed to achievable. But we do notice in the data that, while there is a bit of a distribution, that midwives were pointing to a lack of work-life balance. As we got into the interview data, we saw that was related to call schedules and the demands on their time. Less so in clinic. We found that generally speaking, midwives were very content with their clinic time, but just obviously it's that feeling of when the pager goes off, they feel like there's a disruption to that work-life balance. And when we looked at that Copenhagen Burnout Index, and this is for us, it was an 11-point measure that tapped into feelings of tiredness, both physical tiredness, emotional exhaustion that midwives would experience throughout the course of their day. We did see that there were, generally speaking, when we look at the mean level of burnout, that generally speaking, people were reporting on the moderate to high level of the burnout, or maybe the moderate level would be a sort of fair assessment of burnout, but that the further one got into their career, there was some sort of insulating effect. So midwives who had been in the profession for 10 years or more were less likely to report higher levels of burnout than early or mid-career midwives. So when we delve into both the survey and the interview data, we found that, as we suggested at the outset, it wasn't necessarily that COVID was driving burnout, that COVID was this new and novel factor that was precipitating burnout in ways that had not been experienced. Rather, what we found is midwives were routinely reporting that those systemic factors were dominant: compensation model, call model in particular, wanting to have more diversity in the way that they practiced midwifery, and being able to adapt their engagement with the profession, in ways that were more respecting the stage of life cycle or family stages that they were in. And there was a definite conversation that emerged, or a narrative that emerged, that the clinic experience and the practice experience was generally a positive one, and where the stresses were located tended to be, and obviously the immediacy or the need, so that when someone was paged, that tended to provoke a type of stress, which is fairly understandable, but that the actual experience of delivering and working with parents and working with newborns was something that was still very cherished. So even though burnout was being felt, it wasn't necessarily affecting the ways in which midwives were responding to clients, but there was embedded within that emotional strain, that emotional labor, that compassion fatigue that can so often be felt. So it wasn't a dissatisfaction with the work or the job, it was just the strain felt upon the individual. And when we look at professional supports across the field, because obviously we are not only focused on those factors that might be felt individually, but those factors that are felt at the systemic level. How are the interpersonal supports, either at the practice level or within hospital settings? And generally speaking, I think what is wonderful and the good news takeaway from this story is that there was a strong sense of cohesion within the field, or the sense that for the most part, people felt supported and valued by their teams and certainly by their clients. They felt that what they were doing and are doing, continue to do, is a really empowering role. So a great satisfaction with the profession as practice, but just a recognition that the demands placed upon the individual as a part of the profession, were challenging. If there was one area, and this is, Meg has already flagged this, this idea of where people feel burnout, sometimes the expression of that is that feeling of inadequacy, that feeling that, there is perhaps a need for more training or wanting to feel a greater degree of comfort in the role in order to, feel like you can carry on in your day-to-day without that overwhelming stress. And on to the next slide. So generally speaking, professional culture, I don't want to report that, absolutely everyone felt like everything was rosy all the time. But generally speaking, there was a very positive sense of, a community of midwives. What we're doing here is felt by our community to be important, and we sort of have a good interprofessional culture. Sometimes where there were concerns, they particularly happened at the interprofessional level. So when individuals expressed concerns, it was often in the context of the hospital team and just making sure that everyone was speaking the same language of care and, prioritizing the care of the client in the same way. And often the midwifery model was recognized across professions, but sometimes there was room for clarification or education on what midwives are doing and the nature and level of care that they provide. Because one of the repeated themes was when it was recognized, the hospital staff really said, we're thrilled with what you're doing here. What you're doing here is spectacular. We can't believe we didn't know about this before. But that education piece was very important, because without that, I think a lot of midwives expressed that they weren't being heard. Their vision for client care and their client's vision for care wasn't being seen. And then, picking up on that interprofessional dynamics piece, a strong sense of, as I suggested earlier, within profession support, there is a very strong sense of what we're doing here. There's a cohesiveness to it. There is definitely there's mentorship that exists. There is a strong sense of clinical competence, but where there were challenges, it was really in that piece of getting doctors and nurses on board with the midwifery model, and to I think let midwives sort of provide that type of care that is viewed by clients as such an extraordinarily level of care within the framework of hospital birthing. And so Meg, I'll do this one and then I'll pass it back over to you. So one of the themes that did come up time and time again is the room for greater integration within the hospital culture. So definitely it seemed like there was room for conversations about embedding midwifery or getting midwifery to the table in some of those important conversations that happen around hospital policy. And then also doing something to promote that educational piece, because where there was education, when there was knowledge, where there was shared agreement on delivery of care, there were great working relationships. But when that was missing, or whether there was confusion over responsibility, whether there was a sense of that another healthcare practitioner didn't understand the midwifery model, that created a scope for friction in care. So getting past that, I think, is a lot of it really focused on what can we do at the level of the hospital to promote the integration of midwives. And that doesn't have to be necessarily formal, but just that recognition of the work that midwives are doing.
Great. Thanks, Andrea. So I'm just going to really briefly summarize the call model findings. So midwives expressed that they really wanted a flexibility to work in other call models. Adapting the call model to the life cycle is a very common theme in midwifery. Obviously, there's a lot going on when you're, your early career and you've got a family, and you have things that are also challenging to navigate while you're working as a midwife. And then how to achieve the preferred model of care. So so some of the suggestions really were, talking about really evaluating the course of care compensation model, looking at training and expanded scope, and more opportunities for midwives in leadership positions. And then, as again, expansion of work options, looking at community health options. Midwives want to stay. They really like this work. At least this is what we found. But due to the nature of the way it's organized, it makes it difficult for them to perform in the way that they feel that they want to. And then you get this potentially this we suspect issue around moral injury and vicarious trauma. And so you feel you need to provide this level of care, but then when you work within a fragmented system that's not really set up for you to be able to do that fully, that can in turn reinforce burnout. And then some of the macro level concerns, which Andrea mentioned, are better integration with the hospital politics, leadership at a higher level to be able to represent midwives. I know Abigail Corbin said something earlier this week that really resonated with me around midwives being able to see what that looks like, right? To be able to see what a midwife in leadership looks like so that we can see the way the path looks so that we can advocate and we can represent on higher levels. And that was a suggestion as well. And so I'm just really briefly going to chat a little bit about the current evidence. I know Andrea needs to go. She's got a very important meeting, so she's going to go, and I will stick around and finish up the rest of this part of it and the discussion. So from a current evidence perspective, I mean, this is probably the most daunting slide in the whole presentation. There's a really great meta-analysis, a scoping review that was done recently. There's some really interesting Canadian data from Stahl and Gallagher comparing BC and Alberta midwifery rates of burnout that was done in 2019. There's also really great global research being done, but it's very interesting. And so what I did was I just kind of put on one slide. I'm not going to go into all of it, but if you feel like burnout is a daunting thing, you would be correct, because there are quite a few things that midwives report to be barriers to staying in the profession. And so it's difficult work on a normal day for many midwives. And that's why we're at greater risk of burnout. And there is data to say that we're at greater risk of burnout than nurses and obstetricians. But at this point, we need to really kind of dive into a lot of that and figure out, okay, what is it that we need to be doing about some of these things to help support a way forward. So the factors most commonly associated with burnout are individual characteristics, and then work-related stressors, and then occupational-related stressors. And what I think is interesting is that there are modifiable factors here. There are things that we have some control over, and then there are non-modifiable factors that we don't have a lot of control over, or at least things that we can't immediately address that are going to take more time and a lot of resources. So the most common reasons to leave the profession, I mean, really are, a lot of it is reported as family commitments and an inability to prioritize yourself, which is a risk for burnout in anything, right? So when midwives are not able, when we looked at what are we eating, are we drinking enough water, are we sleeping enough? We really found that taking care of ourselves is difficult because of the nature of the work. That was what we found. And then poor pay is touted in the literature as well. A dissatisfaction with the model, scheduling challenges, a lack of a career pathway, and an ability to find off-call work. And then the professional costs, which are very difficult for a lot of midwives, is a lot to do with just like, what happens if I can't function? If I'm sick, what happens if my kid is sick? What happens? Stories of like, I'm having a miscarriage myself and I can't even find call coverage because, it's just the nature of the work. And so those are the kinds of things, being bullied, harassment, discrimination, racism, those are all things that there is data on that we really, I think, need to obviously keep looking at and finding a way forward. So who's vulnerable? Who is the most vulnerable to burnout? And I think in midwifery, and I haven't seen this in the data, it may exist, but from my own personal observations, I think, midwives I find really value equity and distribution of workload. So it's, when we get into workload, midwives really value making sure that everyone's trying to do their work so that we're not overly impacting. It's like pie, you know, if I'm responsible for 4 slices and then I'm like, I can't do the 2 slices, someone's going to have to take that over. So it's a difficult way to work, where there's, everyone kind of needs everyone. And so midwives who are younger, this is what the research shows, midwives who are younger, who are less experienced, midwives who really empathize very deeply with clients are at risk for burnout. People with minimal coping strategies, and I'll talk very briefly about that. And then something called presenteeism, which we always talk about absenteeism, and people who are absent from work because they're sick or all the time, or they're really not coping well, which is understandable. But presenteeism is also a risk factor for burnout. So that midwife who shows up when they're sick, who is like, I'll do it, I'm here, and really isn't fully functioning, that is also something that puts people at risk for longer term leaves. So that's those midwives we got to watch too. We got to check in with them. And then racialized midwives obviously have a higher risk of burnout. And then there is mixed data on single versus divorced status. So some data says if you're single, you're at higher risk for burnout. And then some data says if you're divorced, you're at higher risk for burnout. So that needs to be teased out a little bit. And so really briefly, just mindful of the time, looking at internal versus external resources. I put this in the presentation, but I'm going to leave it for you if you want to go back and look at it. These are just some things that the data says, these are the things that make a difference in preventing burnout. But what I want to do is really highlight kind of at the 3 levels. So when you look at burnout, it's so complicated because you have individual characteristics at the individual level. There are things about us individually that we have control over or we don't, that put us at risk for burnout. And there are things at the MPG level that put us at risk for burnout. And there are things provincially that put us, and on a systems level that put us at risk for burnout. So it's important for us to kind of look at each of these and then try to figure out where is it that we have some control and where is it that we really don't. And so I always say, if you have a midwife in your practice, I used to say, everyone's got stuff, everyone's got personal responsibilities and aging parents and all of these things that make it difficult for us to balance things. But it's helpful for me as a person, as a midwife and a leader in my practice to really step back and recognize, okay, who are the people here that are more likely to be struggling? And it doesn't mean that they deserve more resources than others, but in some cases they do. And so a little bit more check-in and a little bit more, support. And so from an individual level, there are things we can do. So leadership training is something that when we think of leadership training, we think of it in terms of like, well, if you're a leader, you're going to go get training. But in actual fact, every one of us is a leader in client care. But investing in your own communication skills and your own reflecting of what's going on with you is hugely beneficial. One thing that I always talk about that I think is so interesting is just the concept of storytelling. And so there are many people that walk around and get anxious about things that they think are happening that we're not even really sure are happening. It could be that somebody has called in sick 3 days in a row, as an example. And so, the story that we're telling ourselves is that, they're always sick, or, they're not able to cope or whatever. But people aren't always checking in and asking the question, how are you doing? What's going on? This is what I'm seeing. And so what we do is we get anxious about things that we don't even really know if they're true. So it's checking those stories before we make assumptions about people that help us really identify what the actual issue is so that we can move on. And so there are training programs for that. There are communication workshops that you can do that will help you kind of figure out how to navigate those harder conversations. If you have a midwife who's really struggling and you're really feel like you're constantly compensating for, being able to have those skills to have those conversations can reduce burnout by getting to the bottom of it and moving forward. But that requires, leadership skills. And then the other thing that's missing is mentorship. Like so many midwives really benefit from mentorship, not just clinically, but from a personal skill perspective. How do you function in a busy life? How do you function when you've got so many things on your plate? Some people navigate that really well, and some people really struggle. And so it's really being able to reach out and say, hey, can I chat with you about this? I noticed that you really seem to navigate this really well. Like, can you talk to me a bit about what you do, and being vulnerable enough to ask for help? That's something that I think helps a lot at the individual level. And then understanding what self-care looks like and reflecting on, okay, what do I need? What am I doing right now? What do I need? Do I need a break? Do I need more support? What do I need? And then asking. And then at the midwifery practice group, really quickly, once again, leadership training. It's a different kind of leadership than just being a leader to yourself. But once again, being able to identify risk issues in the practice that are causing burnout. I always talk about the eggshell effect. People feeling like they're walking on eggshells around people is a cause for burnout. So having good leadership in your MPG, being able to kind of to tap into those discussions to see what's going on and how you can support your team to feel like you don't have to walk on eggshells. And then the other one is quality improvement initiatives, and really just having a way to check in with your team about burnout and monitoring it, and being able to input tools that will help you track some of this risk for burnout, which we need more research on, and then a community of practice. So I was just saying, again, Abigail Corbin and Lauren Columbus have just started a leadership community of practice. It's open to any midwife in the province. So if you're interested in participating, reach out to them. You don't have to be a leader to attend, but it does give us a place for us to come together and bounce ideas off of each other and try to navigate some of these things that we know are causing burnout in our own team. So it's one avenue of being able to do that. And then as a leader in an MPG, really being able to set some very clear expectations for roles and responsibilities, personal conduct, appropriate behavior, things that we know we want to minimize, like racism, discrimination, really making sure that you're having those conversations to make sure that people are supported and not experiencing burnout when they really shouldn't be for those reasons. And then provincially, obviously, the AOM is doing work on sustainability of midwifery. It's a very large portfolio, but there are just some things that the AOM that needs to be done at the ministry level. So it's a big thing to think about, but there are things we can do at each level that are small and large. And then this is just a slide. I'm not going to go through it, but it does give you some actual ideas around what you can do. Honestly, self-care makes a huge difference. Like your sleep makes a huge difference. These things that we don't always input into our day-to-day lives really do matter. They help control our mood. They help make work feel less overwhelming. So if you guys do things in your practice groups that you think really help, I would love to hear what you do. And then the last thing I kind of really want to review just super quick is that burnout is contagious. Edelwick and Brodsky in 1980, as far back as 1980, really did a lot of work on the how much burnout permeates teams. And so this happens a lot. And I think everyone can identify in themselves even, or somebody that they work with, that they, when they go to work, it's somebody who's burnt out, and maybe they're more cynical, maybe they're very frustrated, maybe they're really struggling. And it can be something that, changes the energy in the room. And it's the same with birthing people, right? If someone comes in and disrupts the energy in the room, it can have negative consequences. So just being mindful that burnout is really contagious. And, it doesn't mean that you should have to suffer in silence, but it definitely means that there maybe should be, somebody reaching out to say, like, I've noticed that this is kind of what you've been saying and doing, and how are you, and what can we do to support you, and making sure that burnout doesn't sort of spread to other people if we can avoid it. And then future directions really quickly. There's a lot of research to be done. There's a lot of research that's been done. And there's an international network of researchers called WHELM, WHELM, and they have been doing research on burnout for a while. And you can check them out online. But yeah, there is work being done, and more work needs to be done. As you can see, it's a pretty large issue. But yeah, I'd be really curious to see what people do to help buffer burnout, and then, start getting to work on identifying some of these things, like what works and why. How do we prevent burnout, not just treat burnout? looking at continuity of care and the kinds of skills that midwives use to cope in their midwifery work with their midwifery workload. Bullying and racism and burnout in midwifery definitely needs to continue to be explored. I know there's some good work going on currently, and then what's interesting is looking at caseload midwifery. And I know the rhetoric and discourse where I live is very much that, caseload midwifery is a reason for burnout. However, the data doesn't really support that. The data currently supports that caseloading midwifery reduces burnout, but I think it's left to be determined why that's the case. And so the question really is, how many midwives do you need on a team to support a client? Where does that scale tip? And when does burnout become more common? Is it one midwife to 2 clients? Is it 1 to 8? That's sort of something that needs to be explored. So the limitations of the study that we did was that it was a pilot study. So we know it's a snapshot in time. It does confirm findings from pre-existing studies as well. But we're hoping to look at this, tweak the study a bit, and maybe assess a couple of other things that we found. And then I just want to thank the participants that participated in our study. I know it was the middle of a pandemic. You were all so gracious to offer us your time. So thank you. And I welcome any questions or discussion, comments. And if you want to contact Andrea or I, that would be great.
Thank you so much, Meagan. And I know you've been focused on the presentation, but there's already been lots of chatter in the chat. So there are people, I think you've sparked a lot of discussion, and people are thinking already, about where this research could go next, and, kind of looking at, again, different variables, rural versus urban, for example, again, looking at BIPOC midwives and unique experiences that group might have. So there's, lots of discussion already in the chat. I see Kathy has her hand up, so I will let Kathy go first with questions. We have about 15 minutes, so I think we should have time for some good dialogue.
Hi, Meagan.
Hi, how are you?
I'm fine. One of the little bit of pieces that was in your presentation that perked my ears, only because I spent 2 days in Ottawa last week on team collaborative primary care. And one of the things that we certainly identified was, and sadly in Ontario, even though we're 30 years in, how little people know about midwifery. And I think you touched on that. And I mean, it's not comparable to the kinds of things, obviously, that racialized midwives, for example, go through. But I have to say that over the years, it simply got exhausting having to explain again and again and again and again what it is that we can do or can't do. So I keep thinking that that will be hopefully a goal down the road of we're asking for there to be an extensive inventory across the country of exactly what midwives over various provinces do in terms of scope, prescriptive authority, projects, and so on and so forth, so that we don't have to keep reinventing the wheel on that perspective. But I think certainly it's something to be considered in terms of burnout. I'm sure that we know from cases in the past that where relationships are not good, midwives leave faster, right? There's no point in fighting the battle. But thank you for this. I think it's a really good start to examining some of the factors that cause people to leave or to stay. And certainly also gives me some thought to think about selection when we're looking at admitting cohorts. Thanks.
Thanks, Kathy. Yeah, I couldn't agree more. Like, I know that there's definitely like so much related to burnout, even just like going to work and having to explain what you do, over and over again. It's exhausting. I couldn't agree more. And I think it's a precursor to that exhaustion that, it's like just rippling into that first degree, second degree, third degree burnout for sure.
And I think the interprofessional tensions sometimes are part of what then causes people to undermine their confidence and to start that cycle of not feeling clinically, enough or skilled in the ways that they need to be. Remy's got her hand up, and then Derek.
Sorry, I have to push so many buttons to be able to actually talk. I wanted to thank you, first of all, for this presentation. It's excellent. And it's interesting to see, as more and more studies are done of the sort of Canadian landscape, how consistent the findings are. I mean, obviously with slight regional variations, but I was thinking about the Canadian midwifery study. Liz was talking about the study that they did, this one. They all seem to have sort of similar themes, which I think is really helpful and informative. I'm chairing the Midwifery Sustainability Project Steering Committee at the AOM. So I'm like, you know, just gobbling up this information and really looking forward to engaging with the membership to get sort of, you know, their input as well. I think that what to me is kind of scary right now is those external factors, those interprofessional tensions and the HR shortage that really limit our ability to create mitigations at the practice level. So I wanted to share a couple of things that we do in our practice just by way of, you know, giving practical suggestions to people, but also to just say that even for us right now, the fact that there aren't a body, I think it was, I don't know who it was on the chat that said, you know, talk about all of this in the context of the HR shortage. There aren't bodies out there to fill in those gaps. So you're really left, when somebody goes down, to scramble within the existing human resources that you have. We instituted an emergency backup schedule so that each one of us, there's 15 in my practice, takes 2 days of the month where we would normally be off call, and we're available to be called on if somebody goes down, has to be in isolation for COVID. And as much as we all railed against the idea of giving up an extra 2 days, the amount of stress that it relieved, because people didn't have to put out that all points bulletin call for panic. Oh my God, I'm gonna have to be in isolation. Who can give up their vacation to come in and cover me? Because now there's a schedule and you just know who's doing each 24 hours. And so as much as we all thought it would be awful, it's actually turned out to be a really, really great thing. And I recognize that not every practice has the human resources to do that. The other thing is that we work in a team-based model of 3 people with that rotating schedule that a lot of people are familiar with. And we were feeling burnt out and overwhelmed. And so we sat down and we had a conversation as a practice about what caseload we wanted to carry. And we dropped so that between 3 people, each person is doing 34. Rather than the typical 40 or even 36, because we felt like we wanted it to be more manageable when we were on call. And so we made choices that impact our bottom line in terms of operating budget. But I guess I'm just encouraging people to step out of the box a little and not feel like you're constrained. We do have some limited flexibility in the context of what we're working in right now.
Remy, I couldn't agree more. We did the same thing where we sat down and we kind of blew up our schedule just to be like, because we felt like the cognitive, emotional drain of feeling unsafe on call. And like, what if someone gets COVID? So we did the same thing. We offered up more call, which we felt no one was happy about. But when we were on, I think it really got us through the pandemic.
Totally.
A different way. But that's what I mean about the community of practice. I just wish, I know we have the Facebook groups and the things that I think midwives in these MPGs can feel isolated and really not sure what to do. And it's so nice to come together and share what works so that we don't feel so isolated. And so thank you for that.
Eric?
Okay. Thanks for that, Megan. I wonder if you could expand a bit on the compensation a little more. In our surveys and our publications, we found, which were not burnout, they were intention to stay or leave the profession, but the majority of respondents would have preferred a salaried compensation model versus course of care. We didn't really publish it, but I think Saskatchewan and maybe Manitoba, that's their pay policy. They seem to be happier than other provinces.
Yeah, I think, so I think where the results for our study came from, there was frustration with the compensation model because it was inflexible. So it was a stress around like, whereas BC, there was a discussion about the BC model where they kind of break down the course of care and you can get paid for different segments of it. It was this feeling like, I just feel so trapped in, I can't work in any alternate way because I can't get paid. It was like a barrier to, so it was compensation model and call model together that were barriers to me doing anything else. And so midwives were reported just trying to find any other way that they could use their transfer their skills to be able to stay and do the work they wanted to do. So it wasn't, and yeah, like Alberta obviously is, they don't have really an intention to leave because they get paid more, but BC is paid a third less and they have a higher rate of intention to leave. So I think compensation, but we didn't really go into it too much. There was just an overwhelming amount of discussion in the interviews around it's the way I'm paid. Like I'm locked into it. I don't really have another way to break it down and sort of pivot.
And one other thing too, we observed that there was a preference if it could work as part-time work was preferential.
Yes, definitely.
Yeah, and seeing some of that in the chat as well, discussions about the variations between provinces, some of it related to some of those interprofessional dynamics that Kathy had raised, and then different caseload volumes in different provinces, and then the compensation as you've talked about. So lots of, again, factors that we have to think about, and maybe expand your study next to the full province, the full country, Meg.
Right, yeah.
We probably have time for Erin and Liza's questions, and then we will need to wrap up.
Hi, sorry. Something just popped up in front of my screen.
Good afternoon, Megan. How can I help?
I don't know what that started doing. Anyway, you can hear me okay? Yeah, thank you. So I'm Erin. Had been practicing for almost 8 years in Alberta, and I'm currently on a 1 year, who knows how long, sabbatical from work because I have to do it in a different way because I feel like my job was making me abandon my family, even though I loved it. And that's not a good feeling. And you spoke to that. And I think one of the things that I'm wondering is, like, this is the predictors for burnout. But if there's really anything that we're doing so far to talk about what the chances of us coming back from it are. Oh, there, I just had there's a cover on my screen or camera I didn't know existed. Like, and if that's a research place that I haven't even looked if it's something in other fields. And then I think I wanted to just mention something in talking about that, like, difficulty in finding coverage piece. And as someone who, in my evolution to being currently renovating a bathroom and not catching babies, having moved toward doing summers off on the farm and doing physical things that were not on call and very off the grid, and then having that rejuvenating thing, but the impossibility of finding like locum-ish thing and the impact that has on a team and the impact or on like a community of practice and things like that. And the other day on CBC, there was an interview with the president of the Canadian Medical Association speaking about a desire or a possible movement toward national registration for physicians to allow for more mobility between provinces, so that in the circumstance that, like, if your mother is ill in Ontario and you go out there to like spend 3 months helping your mom, then maybe you can actually do some part-time locum work and cover people. And I think often the inflexibility of like where we're stuck with our privileges in a geographic location, I can't really imagine how that could ever work for midwives, but when I was listening to this physician speak, that friend spoke my mind. I mean, I don't know this person, but anyway, I've spoken too much because I know there's not much time, but those are the things I wanted to drop in the thoughts.
Thank you, Erin. I was going to say inflexibility is a common theme. And I'm looking forward to Liz's findings too, to see what provincially was found, because it came through like inflexibility is kind of an underlying issue with compensation call model, schedule, sick cover it. It's a big deal.
I'm just going to expand on that, Megan. Thank you for your presentation. I have been a midwife for 15 years and I'm leaving the profession, so I can appreciate that. I think that something that stands out to me is the inflexibility of what midwives can do, that midwives are limited to catching babies, whereas a nurse or a doctor could go from hospital care to community care to a doctor's office to a nursing home. There's so many options to be a nurse or to be a doctor, but midwives are so limited in what we're allowed to do that even trying to do things in maternal or newborn care that's outside of midwifery, your credentials credentials don't transfer, your experience doesn't transfer. And so we end up losing people from midwifery that have all this experience because they can't not do BCCs unless they're in one of very few funded EMCMs in Ontario.
And those EMCMs require a lot of work to get across the finish line too, right? Like you've got midwives who are scrambling to try to find alternative ways of practicing for other midwives too. And that alone also takes more work and more time. And to set, once again, to Kathy's point, to convince people that we're worthy of our skills being transferred. And we all know that we are, like, we all know that we're very valuable. We have great outcomes, the data supports it, but yeah, it's very, and then yeah, Liz said we heard that at a provincial level too, in focus groups on mental health. So I couldn't agree more. It's like feel like you're standing in a crowded room screaming at the top of your lungs that no one can hear you, that, you know, we can do these things. And I had a client in Emerge last night having a public miscarriage in the middle of the waiting room with her father, and no one would take her in because the system's a gushing wound and there's no staff, right? So it's like we could have had an outpatient clinic that we could have assessed people and consulted OB directly, and they wouldn't have had to waited. Like it's so hard to watch. And then there's the vicarious trauma that we experience by watching it. So it's a pretty complicated issue. Thank you for sharing that.
Lauren?
Sure. Hopefully you can hear me, and I'll try to be quick. I couldn't agree more with Liza and the additional comment around like some of the barriers even to doing that alternative care. And I think that these are really big like systems level barriers that don't allow midwives to work the way they want to based on their life cycles. So that was one of the items you pointed out, Meg. And I think about, you know, physicians in obstetrics who want to keep working in their 60s, even 70s. They can, you know, stop doing call and they can continue to do things like clinic or read ultrasound, things that are easier for them, you know, physically at that life stage. And that would apply as well to midwives with chronic illness or, you know, disability and things like that. Young children, depending on what your situation is. And so I just think, you know, it's a really big problem at a systems level that, you know, working in any of those different ways is very challenging. And aside from, you know, small pools of funds for EMCMs, but even then, you know, there are issues there, as someone pointed out with the college, but even in accessing insurance and things like that, you know, individual physicians get their insurance policies assigned to them as opposed to through an MPG, the way we do it. And so there's just yeah, lots of barriers at that level that are feel hard to address.
I think that's so true. We do need to wrap up in the interest of time, but obviously this is a topic that there's so much interest and passion and a lot that we want to continue to talk about. And so maybe we need to think about ways that discussion can keep going, whether it's through further research with you and Megan and Andrea that you might lead, or whether it is through some of the work that the AOM is going to be doing. So I think it's important that we keep this discussion going, but thank you so much, Megan, and please pass on our thanks and gratitude to Andrea for coming and sharing your results, and such an important piece of work, and congratulations on doing it during the pandemic. And yes, all those midwives who participated, we appreciate their insight. We will have rounds again in a few weeks' time. So join us again Wednesday, April 5th, when Claire Ramlogan-Salanga will be presenting on social justice-based curriculum for Ontario midwifery. And also a plug to keep an eye on your calendar for our annual research symposium, which will happen May 8th till 12th. And we gather every day around the lunch hour, essentially kind of 12 o'clock to 1:30, and we'll have a series of speakers that week. So we'd love to have you join us, and we'll be sending around some information that way. And thank you for filling out the poll today as well. It does help us to know how you hear about these and if you have any other thoughts about the rounds. But thanks again so much, Megan, and have a great rest of the day, everyone.
Thanks, everyone.